Hello, my name is Michael Perdue. I'm with the World Health Organization in Geneva, Switzerland, in the Global Influenza Program. And I'm very happy to be with you today and be a part of this program. And I'd like to talk with you today about one medicine and the approach to the problems we're having with H5N1 avian influenza viruses, as well as other avian influenza viruses infecting humans. So these are animal viruses that are infecting humans. And I'd like to discuss some of the aspects of how we can better the collaboration between the veterinary and the human medical officials for the control of avian and pandemic influenza, and then tell you a little bit about what we do at WHO in response to this zoonotic disease of avian influenza and some of our preparedness plans to try and prevent the next pandemic. So if I can start, today we're going to talk about zoonotic avian influenza and the concept of one medicine to address the human suffering caused by this disease. Not only are we having people infected sporadically with this H5N1 virus, but we're also having destruction of livelihood, changes in cultural practices that have been in existence for millennia with respect to how people deal with the animals that they raise for food, and in some cases animals that might be companion animals. So this is a very important topic, not only for human health, but also for sociological aspects and for just addressing the suffering that has come about as a result of over the last 3 or 4 years of this virus infecting humans. Some of the other things I want to talk about are the challenges of that we're facing at the human and animal interface and how humans interact with, in particular, their poultry. The importance of continuing and enhancing the surveillance for these avian influenza viruses globally and some of the efforts that we are trying to promote to do this. And then finish up talking about the WHO pandemic influenza response structure in Geneva and some of the things that we're doing globally to respond to these continuing avian influenza outbreaks. And then finish up with some conclusions and suggested ways forward and some of the things that we're doing in our group at Geneva to address the problems. Just a quick update, you probably know this, that as of March 15th, this is the WHO data on H5N1 avian influenza in humans since 2003. This is our subnational map, our provincial map, which shows the provinces in which human cases have occurred. We're now dealing with human cases over the last 4 years occurring in 12 different countries, and you can see the distribution of the provinces, and we'll talk a little more about the viruses that are causing these problems globally and what we know about them from WHO. But clearly it's a problem that doesn't appear to be going away. If you look at the epidemiological curve of human infections over the last 3 years, which is shown here, you can see that we're seeing very similar patterns around the winter months of November through March and April, where we get a peak and then a lull during the hotter summer months. And this appears to be playing out again for the 4th year. If you look at the epi curve at the end here, where we don't maybe have quite as many human cases. We've had 18 human cases since the beginning of 2007, but clearly we're beginning to see this sort of peak again, where we had hoped perhaps after the large peak last year that things would subside. The other problem is now we've had, as you can see, the graph is much more colorful than it was. We've had many countries infected with the virus. Over 50 countries have had animal outbreaks with H5N1, and now 12 countries have suffered human infections with these viruses, including 2 most recently, Laos and Nigeria. So it doesn't appear to be a problem that we're going to be able to get rid of soon, but it at least remains a sporadic human infection, and it has not turned into a more widespread infection. And I thought I'd just take a minute to tell you a little bit about why I think this virus is somewhat unique as a zoonotic disease, and something maybe you hadn't thought of. This shows some of the viral zoonotic diseases that are more common. not the bacterial diseases, but the viral zoonotic diseases. And there are a few points that I can make from this. As you probably know, probably 75% of the emerging human diseases are zoonotic in origin. That is, they are natural pathogens of animals that have jumped a barrier to infect humans. And if you look at some of these, most of them are in the RNA virus category. Most of the viral zoonotic diseases are RNA viruses, and RNA viruses are notoriously unstable genetically, so that they vary and mutate quite a bit more than DNA viruses, and certainly more than DNA-containing bacteria. Most of them are carried by vectors, such as mosquitoes, and most of the infections of humans with zoonotic viral diseases are through this route. There are a couple, though, however, that are important to look at. The first, the SARS outbreak that we had 3 years ago, was the coronavirus, in which we clearly had human-to-human transmission. We now know that it likely came from association with bats and excretion in marketplaces, and it probably had the potential for human-to-human, sustained human-human transmission, and could possibly have been a pandemic virus. But if you look at the other RNA viruses here, such as even the Ebola virus, which there is human-to-human transmission, they are a little bit different because they're not transmitted readily in a respiratory route. And the thing that makes the orthomyxoviruses or the influenza viruses unique is that we know that among the orthomyxoviruses, the influenza viruses, that pandemic viruses have arisen over the years, and I'll talk about that. So if you look at sort of the overall picture of viral zoonotic diseases, flu jumps out at you as a very significant, unique organism. We know over the last several years that there have been several events of pandemic potential as defined by WHO, which we define as a significant event where an avian influenza virus or an animal influenza virus infects humans. And this slide just shows several over the last 38 years, I guess. Starting with the famous 1976 H1N1 swine influenza infection in the humans, in which we had several people infected and one death with this swine virus. If you look at this over the years, we've also had infections with H7 virus subtypes, H9 virus subtypes, and of course now, most recently, the H5N1 has dominated the news and also dominated the number of human infections that we're seeing. And interestingly now, the H9N2 virus has just reappeared in Hong Kong in a human, so we have a new human case of H9N2. So I would make the point that we're not just dealing with H5N1. If we're worried about a pandemic, then the potential for this pandemic could come from many different subtypes. Well, from the news and from the most of the influenza virologists out there, we now know that we are probably playing the odds with avian influenza viruses, not only H5N1, but also other subtypes, by allowing them to continue to exist in the environment. And this just shows basically summarizes what we're dealing with. Mutations are random, and mutations occur continually in these viruses, and it's just a matter of chance, most people think, as to whether we will hit a mutation or a sequence confirmation in the virus that could result in a virus that could be transmitted easily between humans. So why are we concerned? We think that the ingredients for a pandemic are abundantly available. The avian influenza viruses, which is shown in this first structure, we know have existed in avian populations for millennia, for as long as we've been able to measure, and we really don't know how long they've been in bird populations, but certainly for a very long time. And they have adapted to remain part of the ecosystem within the avian population. The main components of these viruses are the hemagglutinin, which you probably have heard of, and the neuraminidase, which are embedded in the surface of the virus. And this surface of the virus encloses 8 genes, or 8 RNA segments, which are rapidly mutating RNA segments, which code for the proteins of the virus and allow the virus to replicate and cause disease. We know that also there exists in nature several subtypes of human influenza viruses, which have been circulating for many years, and which are adapted to humans. And the problem we think we may run into is that the avian virus genes may recombine or reassort with the human influenza virus genes, yielding a new subtype of influenza virus, which could become the pandemic strain. This is one mechanism that we know has happened in the past, where the human influenza virus has picked up genes from the avian influenza virus. So it is a significant potential problem for the development of the pandemic. The other possibility for development of a pandemic influenza virus is by mutation of the avian virus, slow mutation and accumulation of mutations that allow it to adapt to humans. And some people think this is what happened in 1918 when the large Spanish influenza virus pandemic occurred, that an avian virus somehow came through a animal host, adapted to mammalian tissue, and became a human pandemic strain. So the fact that this H5N1, as well as other avian influenza viruses, continue to remain in the environment poses a significant problem for health officials, not only for the animal populations, which are in some cases being decimated by these viruses, but for the potential for pandemic virus development. So how do we solve this problem? And here I just thought I'd start off with the discussion on how human and veterinary organizations can work together to say some of the things that we can do to solve the problem. But first I'd like to say one of the things that we cannot do, which is a realistic approach to solving this problem, is that we cannot destroy other species or other ecosystems. We can't blame, for example, wild birds for carrying avian influenza viruses and destroy the wild birds in the ecosystems that they live in. I think both the human health, the WHO, and the animal health organizations all agree on this point, that we have to be judicious in trying to control this disease without destroying ecosystems or other species. That doesn't mean we can't cull animals and do the kinds of things that are being done to reduce the risk to humans, but we have to do it with a view of sustaining our environment. Secondly, transparency in reporting and analysis of this problem is key. Keeping each other informed, and we'll talk more about this, about what we know about these viruses, both in animals from the veterinary side and from humans, on the human side, is very key to continuing to understand how the virus changes and how we may be facing the development of a pandemic. I think another very important part of solving the problem and bringing in both medical and veterinary authorities is a firm and a justifiable assessment of the public health risks. And I think this is an ongoing process now where we're trying to say, what are the real risks of this virus being in the environment for human health? Does the fact that we've had 260 plus human infections with this virus, when there have been must have been hundreds of millions of exposure to the virus, constitute a severe risk, significant risk, no risk? This is kind of information we have to bring together and make public to the general public so that they understand what the real public health risks are. I think we have to all work together to have proactive compensation schemes if we're going to destroy and cull birds in order to keep this virus out of the environment. Then we have to be able to compensate the farmers in a rational way. We have to have effective control measures. We are here at a meeting on vaccination in poultry to control H5N1. And what we need now is good data that shows that this sort of approach is going to be completely effective. We need education of people. I think if you bring people in at the grassroots level, they understand the problems and they understand the messages coming from the veterinary and from the human public health side, and it's the same message, then your education process becomes critical, and that may be as important as stockpiling vaccines or antivirals. So that's a key part of a pandemic control or animal disease control program. And then finally, we'll finish up with this, the technical assistance and open collaborations is key, being able to help countries that cannot face this problem in a joint fashion, and having open collaborations with the ministries in affected countries between the international agencies is obviously very key. So what I'd like to talk about now a little bit is some of the challenges that we are facing that are unique to H5N1 in trying to eradicate the virus and trying to reduce the human risk. One of the things we face is the nature of the virus itself. It's a very diverse virus. It appears to be very ecologically stable. As an influenza virologist for many years, an avian influenza virologist for many years, I've never seen a virus remain so stable in the environment as this H5N1. It has a very peculiar hemagglutinin, that surface protein, which appears to make it capable of going from species to species in the bird population, in addition to allowing it to infect human beings. If you look, I'll show you in a minute, a profile of the genetic complexity of the virus, you will see it's extremely complex, and it is always mutating, continues to mutate, which is one of the real challenges we have in designing programs that will protect humans. Luckily, it is limited in its infection, in number of infections in humans, but the fact that it is infectious for humans makes it also unique. The vast majority of avian influenza viruses are not infectious for humans. So this is a unique situation and immediately puts it in a category that is very different from all the other avian influenza viruses out there in nature. One of the challenges, as everyone knows, is that we have to deal with different and unusual husbandry practices around the world where this virus has landed. And one of the things I'll talk about is the problems we're having in live bird markets, where we have a lot of mixture of different species in an environment in which humans are close together. This presents a really unique challenge. The animal control efforts, as I've mentioned, are variable from country to country, and it's been difficult to measure the success of these. Even in programs such as in Vietnam, where we've had widespread countrywide vaccination, the measuring of the success has been, it's coming, but it's been very difficult to determine in the animal population whether the vaccination is working well. Luckily, in Vietnam, we haven't had any human infections since they started the animal vaccination, so it's a very good, in that sense, it's a good measure of success. We have another variety of surveillance challenges keeping up with these viruses around the world. Countries are always reticent to share the first infections with these viruses because it has huge political and can have huge political and economic impact. We know that there are differences in genotype, again, the variability, and we don't know what risks these differences in genotype pose to humans. There may be some genotypes of H5N1 that are not necessarily infectious for humans. We have people on the web who are making judgments about what they are learning from the open data in the open literature. Web bloggers, and I think they do a service in the sense that they bring it to the public. But if they are making judgments about what's happening in the animal and the human population based upon this public data, this is another one of the challenges that we have to deal with. We have a challenge of real data interpretation, getting the information from the scientist in a timely fashion to tell us what's going on in these viruses, because we have publication issues with people wanting to make sure that they have their publication written before information on the virus comes out. And then we'll talk about collation of surveillance data, where the virus is and what it's doing has been a real challenge. Now, this shows one of the risk factors that we're dealing with. And this is from Jakarta, Indonesia live bird market. What it shows is a cat in a live bird market in Indonesia dragging off a dead chicken. And this I showed to bring up the point that we may not only be dealing with poultry now, but we know that cats and other mammals, scavenger mammals in the wild have been infected with H5N1s, presumably from their consuming or infected birds. And experimental studies have shown in the laboratory that indeed cats can be readily infected by feeding on infected birds. So we may be moving into a realm now in which the companion animal could indeed become a risk factor. This is very difficult to deal with, because now you're having to tell people that their pets may infect them. And we don't want to do that, obviously, because we know that it has profound implications on what people do with their pets, abandoning them and turning them in, or even destroying them. So we don't want to deal with that kind of situation alone. This is clearly an area where the veterinary world and the medical world are going to have to work very closely. If we do have infections from a companion animal, it will open an entirely new door that we haven't actually looked at. But the question is, what is the risk? Does this really pose a significant risk? Can this cat go back home and sleep with a child in Indonesia and cause disease? And the answer is, we are not absolutely sure about the risk. And this is, again, an area where we need to collaborate and work together to provide the public with real assessments of the risk. So I think we could actually use Indonesia as a good example of some of the challenges that we've been talking about with respect to the live bird markets in particular. Indonesia is a very large country. It's been heavily affected with, I think, 81 human cases in the last couple of years, and with the same high mortality that we've seen in other countries. And they have an extensive array of live bird markets throughout Indonesia. They have not a particularly good centralized regulatory government. Much of what goes on in terms of regulation happens at the local provincial level. So it's very important there for the local and provincial human and veterinary health authorities to work together. And one of the interesting things that we've seen in the live bird markets, or in the infections in Indonesia rather, is the fact that we've not been able to attribute many of the cases to direct connection with infected poultry. And this we're seeing more and more of also in places like China, where there's no good records of the source of people being infected with direct contact with infected poultry. In fact, in Indonesia, less than half of the people have shown any direct connection with poultry. And this is data from about 6 months ago, but it's holding up, data from the Indonesian Ministry of Health. So the question is, how much of this virus is in the environment? Are we getting environmental infection of human beings, which of course is of great concern? And the live bird markets are one of the focal points where humans and animals come together to intermix. And so this is one of the risk areas, as I said earlier. How do we propose to measure the risk in these markets? We know there are risks there because we have case histories and studies of exposures of humans in these live bird markets. And we've had these not only in Indonesia, but also in Vietnam and Hong Kong. And not to pick on Indonesia, with respect to these live bird markets, they look very similar in many countries, and they're a very vital part of the people's lifestyle and food source. But the other thing, not only do they serve as a focal point for bringing viruses and animals and humans in the same area, but they can also serve as a point to spread the virus back to villages. So they're a very important area to look at. And we know that the risks are there because of we have this continual mixing of animals and humans from different locations, different sources. We have different species of animals like cats and other scavengers, and different species of birds all mixed together. Lack of hygiene, biosecurity, overcrowding, and the lack of regulatory oversight in many cases for these markets. There are, even with these challenges, there are some success stories with removing the risk to humans from these markets, implementing control measures, and has facilitated the control of outbreaks in some countries. For example, in Hong Kong, in China, the heavily regulated markets now, they're still present, but they're heavily regulated, and they haven't seen H5N1 in the markets or any human infections in many years. The Hong Kong paradigm for developing the live markets includes closure for rest days and veterinary inspection, cleaning, biosecurity, and zoning. So it's been a good model for other live bird markets if the countries wish to keep them open. Some countries are actually now beginning to close the live bird markets because of the risk, but clearly some countries are not. They're going to continue to have these live bird markets as focal points. So the key in a lot of ways is education, both of the local and provincial governments, the veterinary and the human health governments, human health officials, as well as the people working in the markets, so that we have provided a realistic risk assessment of and have in place mechanisms where we can determine if there are infected birds in the market. To that end, that's one of the things that we're very interested in. We're interested in surveillance in the animals and in the environment in the live bird markets. There have been some surveillance studies done in Vietnam, Hong Kong, and China. There is some timely national data, including, particularly in China now, it's more and more coming out, including the surveillance systems that are in place and the type of surveillance they're doing. We're getting some serologic data from countries where vaccination is practiced, but we have to interpret that rather carefully, and it's important that the veterinary and the human health agencies interpret this data together and work together in trying to determine what the extent of infections in the live bird markets are. Generally, they're low. The sporadic presence in poultry associated with, oftentimes mostly associated with outbreaks in the regions. The prevalence can range from 0% in some markets to 6%, and in some markets even higher in a recent study in southern China. The problem is there are also other serotypes and subtypes of avian influenza viruses in these markets, not just H5N1. And this can complicate the picture because we know these viruses can recombine with each other and generate novel viruses that we haven't seen. There does now appear to be a higher isolation rate from ducks and geese in these markets than from chickens, which suggests that there's a predilection perhaps for the H5N1 now to be more commonly found in the ducks and geese and less commonly in the chickens. And there is clearly seasonality with regard to the presence of the virus in these live bird markets. In our group, Dr. Liz Mumford has actually, we've initiated a project in Indonesia in collaboration with the animal health agencies, and we're trying to set up a system of surveillance which is a joint effort between the animal health agencies and the Ministry of Health within the live bird markets and fund this project. So we're very excited about the possibilities of WHO working with FAO, with other interested, the Ministry of Agriculture in Indonesia, the Ministry of Health in Indonesia, to begin routine surveillance in the high-risk markets. And the ultimate goal would be to really look at what are the risks and what are the biosecurity measures that could be followed, and what is the virus load, to get some more indication of what the risk is, and particularly to find out if there is a significant level of non-symptomatic or infections in the markets. Well, when you talk about the human health and the animal health agencies and officials coming together, there are some good success stories. I think if you look at what's happened in Thailand, it would be a very good paradigm model for other countries to work from. They had their first human case early in 2004, and they have in 2004 and 2005 had around 25 cases, I think, and since then have apparently very well controlled the disease, the sporadic disease in humans, very few cases. They have a widespread surveillance program in humans, very widespread surveillance, proactive program going on in birds, so they know what's going on in birds. This is in part because they used to be the third largest poultry exporter in the world, and so this H5N1 hit them very hard. They took very dramatic and drastic measures to address it, including the development of an X-ray program, which was a participatory epidemiology study, which involved villagers going out and swabbing chickens and ducks and finding out where the virus was all over Thailand. It was a very dramatic FAO-supported program. They, of course, have involvement at all ministerial levels, and they chose not to do any vaccination, so that if you have in place the kind of surveillance that they have, clearly vaccination can be precluded because you know when the virus pops up, where it is, and what it's doing. I put also in here, there's no point in the blame game. I think to make the point that, particularly in Thailand and in other countries, there's always this, after an outbreak of H5N1 and human cases occur, tendency for the human health officials to blame the veterinary health officials for not keeping up, a clean, uninfected food source. And I think from Thailand and many other countries, we found that there's just no point in this idea of trying to blame one sector or one agency or one group of people. We're all in it together, and I think in Thailand, without a doubt, they have moved towards this idea of we're all in this together, and we're all trying to control this disease together. If you go to their websites, they have a very current surveillance information, both from human and animal sectors on H5N1, which they've had for the last couple of years. So the websites are shown here. So they're really, I think, one of the success stories. We're still having new countries infected. For example, Laos just had its first 2 human cases. In Laos, there's currently no systematic surveillance in the country. The cases were actually diagnosed outside the country. FAO and WHO sponsored surveillance in Laos, first identified the presence of the human H5N1 lethal virus, the so-called clade 2.3 virus, before the human cases occurred. But they have responded, as many other countries do, to the human cases with committees put together. That these prime ministerial level committees are generally put together for countries that are at risk or countries that have outbreaks, that include all of the pertinent agencies, the Ministry of Health, Ministry of Agriculture, other ministries. They generally will request WHO assistance and generally work through the WHO country office within the country. And we generally move to a point where we get transparent updates on these H5N1 viruses. And so it's just kind of a contrast in the capabilities between 2 different countries in the Southeast Asian Peninsula and the kind of challenges that we have to deal with in getting the human and the veterinary worlds to work together. So I'll come back to that at the end to just make a few points, but now what I would like to do is to go through what we do at WHO in response to these continuing infections and the possibility of a pandemic arising. Over the last year, we have greatly expanded our programs at WHO. When I joined 2.5 years ago, the global influenza program was about 5 people. We are now up to 26 total staff and 4 teams on the program. We work in the Department of Epidemic and Pandemic Alert and Response. We have, as I said, 4 teams that concentrate exclusively on influenza, and our group is called the Human-Animal Interface Team. In addition, there's a number of other additional groups at WHO that have been brought into the pandemic response structure: the alert and response operations, food safety, zoonotic diseases, and international health regulations people, and I'll talk a little bit about that in just a minute. Also, we deal very closely with our regional offices and WHO country offices, our regional communicable disease advisors on outbreaks, and so this is a very large-scale response now to the potential for the pandemic. One thing that's happened is this new international health regulations is called for an influenza pandemic task force, which is what it's now called. It'll also eventually be called an expert committee for evaluating outbreaks of zoonotic diseases in countries. And the member countries of member states of WHO have all now signed on to this new international health regulations, which gives a little more teeth, I think, to WHO's ability to request information from countries where outbreaks of zoonotic diseases are occurring. And this will have a very strong influence on how we deal with outbreaks of novel subtypes of H5N1 in the future. If you look at the variety of functions, I won't go through all these, that we have to deal with when dealing with implementing a strategic action plan to prevent a pandemic, you get some idea of how complex this is, the number of things that we have to deal with, and the number of people that we try to provide leadership and guidance, to use the people to provide leadership and guidance on these various boxes of issues that are related to trying to prevent the pandemic. One of the things that I had the opportunity to be involved with was our Strategic Health Operations Center, which is called the Shock Room, which is a center in which we try to coordinate all the activities related to outbreak response. And during the turkey response, we set this operation up, and it's coordinated overall by the senior management at WHO, but there's an event manager who decides on a group of teams that would be needed for the outbreak response. And in our case, we had 6 teams that dealt with the clinical aspects of the H5N1 outbreak in patients in Turkey, the epidemiological aspects, laboratory aspects, social mobilization, food safety, communications, and then a group dealing with the operational support, getting people on the plane to go to the site to deal with the outbreaks and to deal with WHO's overall response to the outbreak in Turkey. And so this is now implemented in times of emergency, so that if the Director General or decides to call an outbreak an emergency scenario, so to speak, then the shock room is activated, and we're there as needed, 24 hours a day or basically as needed. That's one element of the response. Our oldest element of responding for influenza infections is our global surveillance network, which is shown here, which includes 115 national influenza centers around the world. In many countries, there's more than one laboratory, National Influenza Center. There are many also national networks, for example, in the EU and in the United States and Canada and Russia, which have their own national networks for influenza. And then there's 4 large human influenza collaborating centers in CDC, in Atlanta, in London, in Tokyo, and in Melbourne. And these laboratories receive these laboratories receive human influenza samples from around the world, from doctors' offices, from public health laboratories, and they do initial analysis, and interesting isolates then are passed on to the large collaborating centers. The large collaborating centers now are looking at upwards of 200,000 samples a year, and looking at anywhere from 15 to 40,000 isolates, and as many as 6,000 viruses that are being completely sequence characterized every year by the collaborating center network. So this is a vital part of the WHO response for seasonal influenza. These laboratories are also involved, obviously, in avian influenza if they receive samples from a doctor's office, and they now have the capability of determining if this is an H5 virus or if it's a standard seasonal influenza virus. So we're moving towards this widespread network of laboratories that are capable of finding H5N1 infections and other new subtypes infections in humans. Just briefly, the overall network for pandemic preparedness includes all the laboratories that we associate with, as shown here, under the WHO Global Influenza Program. Within the surveillance network, I mentioned the National Influenza Center. We also have 8 human H5 reference laboratories that develop reagents for H5N1 viruses and collaborate closely with the animal groups. The group that works out of our team is the WHO Working Group on Research at the Human-Animal Interface. We collaborate directly with the OIE FAO network, OFLU network, which also collaborates with the H5 reference centers. Then we also have a new network, a research network that's established in Southeast Asia that's a collaborative project with NIH and Burroughs Wellcome and WHO to try to get more information on human infections with H5N1 viruses. So this is just an overview. We have a lot of collaborating laboratories that we work with very closely in following these viruses. One of the things these laboratories do is to evaluate the antigenic structure of avian, of the H5N1 viruses. This is a picture of the distribution that I showed you earlier, and what we now know is that there are 4 sort of major antigenic groups of these viruses. It's a very rough approximation of where they lie that have occurred around the world. The original outbreak virus was the so-called clade 1 virus in Southeast Asian Peninsula, a virus which is predominant in the Indonesia archipelago, and a virus in southern China, and then the virus that moved from Qinghai province, China, into Europe last year, which is so-called clade 2 viruses. So if you look at the capability of antibodies to react with these viruses, and do antigenic comparison, what you see is that they fall into genetic clades which are clearly segregated from each other and which do not necessarily cross-react. So what I'm saying is, even though all these viruses are H5N1 viruses, they react differently with antibodies, so that a vaccine made against a clade 1 virus, for example, here, may not protect as well against the clade 2 viruses. This is the kind of work that our collaborating laboratories do to evaluate the effectiveness of the proposed pandemic vaccine viruses. The other reason I show this, and this was just recently on our website, this is just some of the data that was used to develop this this picture of the genetic diversity and the antigenic diversity of these viruses. If you look at some of these viruses, I've marked here in boxes because these are viruses that, and this would refer to several viruses up here actually, this empty box at the top. These represent viruses that have been collected by active surveillance of laboratories. In other words, they were not associated with an outbreak. They were people who were going out looking for the virus. And the reason I show it is that this active surveillance, now we are clearly picking up these important genetic clades by doing active surveillance for these viruses. And so the idea of enhancing and doing more of this active surveillance will allow us to hopefully stay one step ahead of what the virus is doing in nature, and we can propose correct vaccines, correct diagnostics based upon the genetic diversity. The other thing I'll mention is, if you look at these are also marked as vaccine candidates that have been developed in WHO laboratories. And if you look at this whooping swan Mongolia, this is a perfect example of collaboration between animal health agencies and WHO, where the USDA-sponsored research picked up this whooping swan virus from Mongolia in 2005. This was transferred to the WHO Collaborating Center, which made a vaccine candidate, and now this will be one of the vaccine candidates for human vaccines for these H5N1 viruses. So it's a very good example of how they work together. As you probably know, WHO is trying to make sure we don't have the next pandemic, but if we do, we at least want to have some indication of how to deal with it. And so over the years, they've developed this pandemic preparedness plan to give us some indication of where we are and how far we are along the road to the development of a full-blown influenza pandemic. Even with all the activity that's been going on over the last few years, we're still only at pandemic level 3, or pandemic preparedness level 3, where we have no or only inefficient human-to-human transmission of the H5N1. We have not moved to the point where there's strong enough evidence for increased human-to-human transmission to make a statement from WHO regarding the potential for the pandemic. As you might imagine, as you move from this level 3 to level 4 and level 4 to level 5, you have tremendous direct effects on the countries where the virus is found. And so this is not a decision to be taken lightly in terms of making the decision to call an increase in the pandemic preparedness level. But we are trying to avoid what we've seen 3 times in the 20th century, these worldwide influenza pandemics from a new subtype. The most famous, of course, the Spanish influenza pandemic of 1918, the so-called Spanish flu. Even though it probably had very little to do with development in Spain, it's still called the Spanish flu because they're the first ones that reported it. But it killed upwards of 50 million people. We're still living with the legacy of this H1N1 as viruses reassorted from this parent stock with an avian virus in 1957 and generated a new subtype, H2N2, and then in 1968 a new subtype, H3N2, which we're still dealing with today in circulating in humans and causing seasonal influenza. We know, as I said, by announcing a pandemic that you have a tremendous impact on a country. If you can just see this from the data from the SARS outbreak of 2003, where the WHO Global Alert was announced here, which would be equivalent to announcing a phase change in the pandemic preparedness plan, and you can see what happened to the travel tourist arrivals in the various affected countries after that, and it takes a long time to recover. So it's important that we are dealing with the correct surveillance data, the correct genetic information, the correct antigenic information, the correct epidemiological information to make this kind of a statement about changing the pandemic preparedness level. So it's a very serious consideration, and one of the reasons I think that we have really increased the number of people at WHO looking at the evolution and the epidemiology of these H5N1 viruses. Just to close with some of the recent WHO responses, there's a lot of information on our website, which I won't go into, and it's reasonably easy to navigate after you practiced a little while, but we have some recent responses. We have expanded our support for surveillance and training in lab networks and coordination with animal agencies. One of the things that our group, the Animal Human Interface Group, is directly responsible for. Recently had a large consultation to develop global action plan for increasing pandemic vaccine availability around the world. That can be found on the web. We've recently increased rapid response and containment training around the world and gotten quite a number of funds to go into countries and give the WHO perspective on what rapid response and containment of a potential pandemic should be. The group I work with, the Working Group on Human-Animal Interface, just last year had a large consultation where we sort of began to define the research agenda for H5N1 and what we should be doing to move forward. And it had a lot to do with enhancing and supporting more surveillance. The Strategic Response Pandemic Preparedness Plan is still valid on the WHO website, which includes human surveillance suggestions so that we find very early cases of H5N1, various protocols for investigation, diagnostic tools, situation assessment, monitoring, containment, a lot of information in these pandemic preparedness plans. There's also a pandemic preparedness checklist so that the countries can tell if they're moving in the right direction. We've had a great response in the last couple of years. 6 months ago was actually a year and a half ago, where we had only less than 50 countries that had a pandemic preparedness plan developed in their country. Now we have over 140 countries which have provided pandemic preparedness plans based upon the WHO suggestions. But we still have to go forward, operationalize these, have exercises, try to develop international coordination, particularly with respect to borders and stockpile and which stockpiles will be available for which emergencies in which countries. We try at WHO to do global coordination, scientific knowledge and management, collaborations in vaccine development, diagnosis, public health, a number of variety of publications and guidelines, again, all of which are on the web, on the WHO website, and many other things in the works. This is part of that draft protocol for rapid response and containment, which is on the web, which was just one of the things that can be downloaded. In our group, we have noticed that active surveillance has increased dramatically. This is really one area where the joint efforts for one medicine can come together. The National Institutes of Health in the U.S. has sponsored Asian surveillance for many years. The North American surveillance in wild birds, for example, has just increased with the U.S. Geological Survey coming in and putting a lot of money into surveillance in wild birds, looking specifically for zoonotic avian influenza viruses. The European Union has huge efforts increasing now in direct collaboration with ornithologists that are marking birds, which birds are infected, which birds are migrating, all the information you'd like to know about the ecology of this virus as it is carried now by wild birds. What I've seen in a lot of the regional meetings is a really increased commitment to active surveillance, going out and looking for the virus, and this is jointly between the animal health and the human health agencies. They all seem to be wanting to get on board to go out and survey wild birds, to do active surveillance in poultry populations to increase the knowledge. So I think in general, we've seen a huge increase in the interest in surveillance, and I think this is only going to be good because we know where this virus is, as I said. We know where it is and what it's doing. We have a much better chance of preventing it from becoming a pandemic virus. There's a lot more funding available. One of the challenges that we have now is do we try to coordinate globally the surveillance activities that are going on, and if so, how? And this is one of the things that our group is very interested in. And we've expanded our efforts at the human and animal interface. We do have more specific funding for the live bird market activities that we're working with. Coordination of the working group, as I mentioned, comes in our group. Also, we work closely with FAO and OIE in the new early warning system called GLUES that will attempt to incorporate the prospective and the outbreak surveillance into one platform that WHO and OIE and FAO can all use. So this is a new initiative that is moving forward that is direct collaboration between the international agencies. We have specific increased laboratory support requested in the form of a bioinformaticist to work on development of the surveillance platform, linking it with sequences to include a website that will be used jointly by OIE and FAO and also other agricultural agencies around the world that want to see what's happening to these viruses at the genetic level. So that's one of our new initiatives. Ways forward, well, understanding the risk factors, again, is key to protect both human and animal populations from exposure. The interaction, of course, between public health and animal health optimizes the capability of surveillance. More money, more interest, and control, prevention, and education. We think diagnosis and detection capacity could benefit from additional technical cooperation between the laboratory personnel, between the people who work in the human labs and the people who work in the animal labs. We find that if you bring these guys together, they like to talk to each other about what they're doing at the bench. And so one of the initiatives is to try to bring the human and the animal laboratories together to discuss the issues related to diagnosis of H5N1. We're increasing our cross-training in bioinformatics and other genetic analysis between the human and animal sectors. We'll be having 2 or 3 bioinformatics workshops coming up that will be jointly facilitated by human and animal agencies. Again, grassroots level, I've already mentioned that. Also bringing public health and veterinary public officials together for training and discussions so that actually many times in these countries some of the veterinary and the human health people have not met each other. So I mean, if we can bring together meetings proactively where the human and public health and the veterinary public health officials come together, it will be good. I already mentioned the joint surveillance platform. We're thinking about perhaps developing, since we know now a lot about what happens when H5N1 arrives in the country and the interactions that occur between the human and the veterinary agencies, developing WHO, FAO, OIE guidelines for intra-national cooperation on zoonotic diseases. But this would have to be coordinated with our efforts on implementing the international health regulations, which is an important aspect of WHO. Our strategy is implementing the international health regulations. And finally, I think, without a doubt, more open dialogue, open communications about the challenges that each side faces, the human side and the veterinary side, can only help and can only move towards a situation where we work for not necessarily pandemic preparedness, but pandemic prevention preparedness, so that we never have to deal with the virus becoming established in the human population. We keep it at that level in the animals, and eventually, hopefully, to remove it from the animal population altogether. I thank you for your attention.